Hello friends, I am Dr. Niraj Vasavada, consultant spine surgeon, Zydus Hospital, Ahmedabad. Today I am here to take you through the step-by-step surgical technique for Trans-Kambin lumbar interbody fusion. I thank my colleague Dr. Pratik Lodha and Dr. Bharat Danani for helping me prepare this video. I also thank Solco Biomedicals for supporting the video. I have nothing to disclose and I urge you, please don't distribute this video. This is solely for your purpose, not for your groups. There are various ways to fuse a lumbar spine. It started with PLIF, then the TLIF was introduced. MIS TLIF was introduced to preserve the muscle. Then the anterolateral and anterior techniques like DLIF, OLIF and ALIF were introduced as an indirect decompression technique. Today, we are here to discuss about a new technique that is between the TLIF and the psoas techniques, and that is what we call as KLIF or Trans-Kambin lumbar interbody fusion. Now, so far, the current gold standard is MIS TLIF. So what's not ideal according to me in this current gold standard? If we look at MIS TLIF, it does invade epidural space in equivocal violence as if we are doing an open TLIF. It uses a smaller cage profile, and when it goes more than 3 levels, the studies have demonstrated that MIS TLIF loses its advantage. The foraminal height restoration is much inferior to DLIF or ATP, that is OLIF approaches. So when you reflect, there is a need for a better technique, especially in multi-level surgeries. ATP approach or anterolateral approach has promised a lot, but it is an unfamiliar approach to many. Restricted conducive vascular corridors are required to do these cases. Change in position is required from lateral to posterior unless you have expensive 3D navigation. Revision sometimes is difficult, and if you meet with complications, although rare, but they are nightmarish. So a personal reflection again comes that despite it supersedes MIS TLIF, cost and familiarity the approaches and logistical challenges doesn't make it a technique for mass. If you look at this two image, on the left, you can see that this is the corridor from where you can easily do an OLIF. But what if you get this kind of cases where there is angry psoas and bifurcation has already happened? If you try to do anterolateral technique, you are endangering a vascular structure. So this is not ideal for that L4-5 or a right-sided image that you see. If you look at this image, there are so many vital organs or vital structures will come in your way while performing this technique. Hence, OLIF has not found its place in armamentarium, specifically in our Indian context. This is how we know OLIF achieves the indirect decompression. It releases the disc properly and adequately. It excises the annulus and does near total discectomy, and it achieves a concentric distraction of the disc space by which the indirect decompression happens. So if we come to KLIF, my indications and contraindications for KLIF, the indications are whenever there is indirect decompression or segmental deformity correction is possible, when you have a collapsed disc space with sclerotic end plates so that you can easily achieve distraction against this robust end plates. You have conducive L5S1, which is not possible while doing OLIF, but in a conducive L5S1, KLIF is possible to do. Reasonably preserved segmental lordosis, especially as L4-5-5S1, because you want to achieve 3/4 of your lordosis at this level. The contraindications would be segmental kyphosis, because kyphosis correction is extremely difficult while doing this technique. Whenever you have osteoporotic bone, it is not recommended because your end plate will not be strong enough to withstand the indirect decompression and you may have end plate damage. When you are doing a large adult deformity correction, KLIF is not a recommended technique. Now, KLIF is performed from a Kambin's triangle. So, Kambin's triangle is generally formed between the exiting nerve root and the traversing nerve root, along with bordered by this pedicle or a superior articular fasces as it is available here. And this is the triangle from which you have to enter. If you see to this image, this is the triangle which is formed, and the area or the maximum diameter of Kambin's triangle generally has been found around 9.5 to 10 millimeter in size in a normal population. And as you go higher in lumbar spine, the size of Kambin's triangle gradually reduces. So this is from where we will enter. We will enter at the lateral most aspect of the Kambin's triangle at the lateral border of the pedicle, and will go inside the Kambin's triangle. As you go in, it will become wider for insertion of this cage and other instruments. This is the representative image to show that how the Kambin's triangle would look like. These are my initial cases where I had done an epidurogram to identify how does the Kambin triangle looks. So you can see that, this is the exiting nerve root which is going, and this is the traversing nerve root. This is the pedicle. So this is the area of Kambin's triangle within which you have to work to do this fusion. If we look at the basic steps of the surgery, it is done always under prone position. Approach entry point is approximately 9 to 10 centimeter lateral to midline. Entry point is ideally between the Kambin's approach point and Young approach point. I will take you through this in a while. Needle first targets the superior articular process, then it is slide over it to reach on the posterolateral annulus at its inferior border. At this point, I always stimulate it with a back needle under the neuromonitoring. Then the disc space preparation is done over inserted guide wires. Then the grafting is done from a funnel and cage is inserted. And finally, the percutaneous pedicle screw fixations are done. I'll take you through all these steps step by step. So this is the needle entry point. If you see this area, the Kambin zone, which is generally at the lateral border of the quadratus lumborum, or the flank of your back starts curving. That is the area which is called the Kambin's approach point or a lateral border of the quadratus lumborum. Yes approach, the Young's approach is slightly more lateral, and I'll take you through in the next slide how to take this Young's entry point in our patient. So you can see this is again a representative image. This is this side, the top side of your screen is right side of the patient. Bottom side of the screen is the left side of the patient. This is the electrode, which is the cranial side of the patient, and right side of the screen is the inferior or the gluteal side of the patient. The pedicle has been drawn as L4 and L5. Red line is the midline and two parallel lines are the disc space. So this is the basic marking what we have done. Then what we do is we put a needle in a horizontal position on the disc space parallel to it, and then mark with a line, and then under lateral image intensifier, this needle is made parallel to the disc space all the way to the anterior margin of the disc space, and a line is drawn. Where these two lines will meet, that particular line is the Young's entry point. Now this yellow arrow that shows the lateral border of the quadratus lumborum, and that is the Kambin's entry point. This where these two lines meet, the second yellow arrow, that is where the Young's entry point comes. I traditionally prefer to take a point between these two so that if I need to do an orthogonal maneuver, it is possible. Now if you think, if you are going through the Young's entry point, generally it is quite lateral and it goes into posterior annulus and into the epidural space easily. But here we have to go from posterolateral corner of the annulus to the anterolateral corner of the opposite side annulus, and that is why you will have to do an orthogonal maneuver in a reverse position than what you do in OLIF. In OLIF, we generally do the maneuver to keep the cage in horizontal position. Here the orthogonal maneuver is done to put a cage in more oblique fashion. So this is the entry point, how I would take my entry. This is just the image with which I have taken the entry from the point of entry which I just showed. Now if we look at the schematic diagram and how we go step by step, first we will show the schematic diagram and then I'll show you the actual images on the C-arm. So this is how the patient would look. The blue are the roots and dura, which easily you can see. The first, once we take the entry, my needle will hit on the SAP or the facet joint, and AP and lateral it would look like this. So this is the image of intraoperatively taken for the patient. If you notice,
the AP, your needle will never cross the lateral border of the pedicle while targeting your facet joint. Once you have sure, you have to gradually advance your needle to the posterolateral corner of the inferior end plate, which is a safe entry point because it is away from the exiting nerve root, and then you have to glide your needle inside the disc space. So this is again the image intraoperatively. You can see that my Jamshidi needle is targeting the posterolateral corner of the disc space, and if you see that this needle entry in AP will be somewhere around midpoint of the pedicle or midline of both the pedicle margins. It should never cross the medial margin of your pedicle, otherwise you may enter into the medial side of the epidural space. Once you have done that, you can insert a guide wire, and guide wire then goes inside the disc space, and then rest of the procedure is done over the guide wire. This is again the image which shows that guide wire goes all the way to the lateral aspect of the annulus, and when your needle in lateral is at the anterior border of the disc space. So this is very important to achieve the optimal position of your cage, that in AP your guide wire should go all the way to the medial border of the pedicle or beyond that slightly, and in lateral your needle should be at the anterior margin of the annulus. Now in certain cases like this, when you have a narrow anteroposterior diameter of your vertebra and broad mediolateral diameter, achieving this angulation, which is ideal as per the yellow arrow, it will end up your needle somewhere into the opposite side, only 1/3 margin, not all the way to the horizontal, because if you want to go all the way to the lateral border on the opposite margin, you will have to go very lateral, and you risk entering into the retroperitoneal space, which is not advisable in most of the patient, as you may even enter into the psoas muscle. So this is the case. This is the particular case wherein this oval kind of a vertebral body, and you can see if your needle is crossing just midline and approaching the medial border of the pedicle, that should be enough and ideal for the position. Now while doing that, you can slightly do an orthogonal maneuver in reverse direction so that you can achieve more better obliquity. So this is now the guide wire which is inserted inside. At this point, I will use my trigger electrode. Now you can use this two-way. You can use standard pedicle stimulator, which we use in intraoperative monitoring, or you can use a Bach needle to stimulate your nerve. If you find any stimulation, you have to reposition your needle and guide wire. You start with 0.5 milliampere of current, and then you can go to 1, 1.5 and 2. I go up to 3, but it is said that up to 2, if you get to the safety, then your ENR is far away from where you are putting your cage on the annulus. So that makes your surgery safer. Now, this is the obturator which will go on the guide wire. Obturator will open the disc space. It will incise the annulus with its conical tip and will go inside this all the way to open annulus, and at the same time achieve some amount of distraction. So this is how it will go on the guide wire, and this is the final position of your obturator. This is how it looks when entering into the annulus on the C-arm, and you see that this guide obturator has gone all the way on the disc space, and you can very easily see that it has distracted the end plate. Now this maneuver itself is sufficient enough to achieve an indirect decompression. Now you can use a small obturator or a large obturator depending on what kind of distraction you want to achieve in your patient. At this stage, when you have achieved this adequate indirect decompression or opening of the disc space, you can insert guide wire on the opposite side of the pedicle to keep it tall while doing other procedures so that it doesn't collapse once your obturator is removed. So pedicle screw will hold the space in position in an distracted fashion. You can see that this I have inserted the pedicle screws inside. Now to do further instrumentation, every time you will have to go through the quadratus lumborum and paraspinal posterior musculature. So instead, what I have started using is a table mount fixed tubular retractor system. Our standard MIA Steelip tubular retractor system, 70 millimeter, 19 mm to 20 millimeter diameter tube, which I dock on the posterolateral aspect of the spine above or posterior to the transverse process, and entire other instrumentation is done from this tube, so that every time I don't have to abrade the muscle fiber by inserting the shaver's cage or other curates and other instrumentation. So once you have fixed the screw, you remove the obturator, and then standard tubular dilators are inserted. Your smallest dilator will go all the way up to the disc margin, and next dilators will dock on the facet, and this is how it will look like on your patient. This is, you can see that, this is a schematic view. Your tube is positioned posterior to your transverse process, and when you see that, from the skin, your tube will be visible outside, and you can do rest of the instrumentation from this tube. This is how it looks like. You can see this, there is a trigger electrode over here. This tube is docked, and the table mount arm will hold your tube in position, and rest of the procedure you can do very easily from this. Now, after doing this, you can reinsert the K-wire. The K-wire is already there, and over which you can use this box shaver, and box shaver will prepare your end plate. There are sequential sizes of box shavers. It starts from 8 millimeter and goes up to 13 millimeter size, so that you can achieve your disc preparation adequately. And I'll show you in a slide how much disc material we can remove with this. Once this is done, you can reinsert your obturator again, and over which the cannula or a sleeve with a beveled end is introduced. The bevel opening will face away from the ENR, so the other side protects your exiting nerve root from the instrumentation. Once this is done, then through this cannula, you can see this image where cannula has been fashioned inside the disc space. Once this is done, you can insert your disc forceps inside the disc from this cannula, and then you can grab whatever loose disc material you can have and take it out. Once that is done, there is a specialized 45-degree angled curate which passes from this cannula, and you can prepare your superior and inferior end plates from this cannula. So this is the pictorial depiction of this image, and now we can see the C-arm images. You can see that, this is the shaver, box shaver, which goes inside the disc space over the guide wire, and the box the disc space is prepared. This is the disc forceps which is passed through this sleeve, and residual disc material is removed. This is the 45-degree angled curate which will prepare your superior and inferior end plates, and can also collect the debris which you can take it out from the sleeve. Now, after this, over guide wire, the funnel is introduced, filled with your graft material, which can be a tricalcium phosphate granules or allograft or autograft, depending on your preference, and it is impacted inside the disc space. So this you can see how, this cannula is inserted and graft is introduced. I traditionally prefer to use tricalcium phosphate or allograft mixed with the bone marrow of your patient taken from iliac crest. We'll take you through some of the images, intraoperative images, to make you orient how we are doing. So this is first the patient, second is needle insertion, then the guide wire, then the Bach needle stimulation, and then the obturator is inserted. Over obturator, the cannula is inserted, then the tubular dilators, and you can see the opposite side screws are also inserted. The table mount tube is inserted over it. You can see very easily how it looks like here. Now these are the foraminoplasty reamers which I use sometimes to open the foramen, so that this reamer will drill the SAP, and that SAP will widen the Trans-Kambin zone, and you can even insert 13 mm, 14 mm cage, which I have done in my practice. Now this is the marrow which I have taken out from the iliac crest, and this is the tricalcium phosphate. We'll mix it and we'll insert into the cage. At this stage, I sometimes prefer to use endoscope to do the lavage and remove whatever residual disc materials are there, and check the end plate whether if it has been prepared properly or not. And this is the cage which we insert. So this is the amount of disc material I have removed from a completely collapsed L5S1 disc space. So you can achieve a very good discectomy with this technique. in my initial cases to see that how this ENR will be when I'm inserting the guide wire. This particular image shows that I have docked this tube on the facet joint. I have done a SAP excision like we do in MI steel, and I have seen that from where the guide wire is entering, you can see there is no exiting nerve root visible, and this is the disc space and this is my guide wire which goes inside the disc space. So it is scary, but if you look at it, it is much safer than it is actually thought of. This is the end plate which we have seen after preparing through the Trans-Kambin approach from the same tubular dilator. Now I have also taken an endoscopy view to see that how beautifully the end plates are prepared. You can see this end plates and you can see the bleeding bone which is prepared via using this curette and box shavers. So that provides an adequate end plate preparation for a complete fusion bed. Now if we talk about cage, this is a blue dolphin cage designed by Solco, and you can see that this is the height of the cage, this is width of the cage, and this is the conical tip of the cage. Now all these three things are very important to remember. Let us take one by one. First we take the conical tip. So conical tip, when you are inserting that conical tip inside the disc space, this conical tip gradually will expand its way so that it will open up the end plate. And not only that, this conical tip will push the ENR away while cage is getting inside the disc space, making it a very safe entry. This is the only cage available in India, to the best of my knowledge, where we have provided a very long conical tip for cage to go inside the disc space very easily. Now, if we talk about height and width, the width is fixed at 9.5 so that cage, when it is inserted into the Trans-Kambin zone, it is always inserted with a 9.5 millimeter width in superior and inferior space, and then it is rotated to its height so that the end plates are in flush with the serrations and the graft. I'll show you in the next image how it is happening, but please bear in mind that always insert your cage at its width, not at its height. Width will remain same while the height will start from 8 millimeter and goes up to 14 millimeter of the cage. So far, I guess Solco has made 30 mm cage as a fixed length of the cage, but I think we are in a process to design into 25 and 35 also for a smaller and a bigger patients in our patient. So this is the width of the patient which is seen, and this is the height of the patient. You can see that cage is slightly going lordotic so that it will prevent the back out of the cage if at all the segment is loose. And this is the handle which has a 90 degree handle provided. So you insert with the handle in a horizontal position. Handle is in a horizontal position. That will keep the width in superior and inferior direction, and then you rotate it 90 degree so that height will come in contact with the superior and inferior end plate. This is how it will happen. You insert your cage with your width, and that will make your graft not in contact with the end plate, and then you rotate it 90 degree so that your graft and serration comes in contact with your end plate. So this is how you have to rotate your cage 90 degree so that you achieve an optimal position. So these are few of our cases where we have done the case. This is a multi-level KLIF. You can see that how beautifully the cage is placed, exactly 45 degree going from posterolateral to anterolateral case. And you can see that this patient started walking within just 4 to 5 hours of surgery with extremely minimal blood loss. You can see that this case shows how badly collapsed foraminal heights are, and post Trans-Kambin fusion you can achieve that foraminal height adequate for your patient decompression. This is a very high BMI patient. You can see that tube is docked and KLIF is done. In this particular case, I had used a traditional instruments without using the sleeve, but I recommend not to do it in your early cases, and you can see how beautifully the lordosis and the foraminal height has been restored. This is the grade 2 spondylolisthesis, wherein just inserting the obturator, you can see that it has opened and reduced partially the listhesis. And once we have inserted the screw on the opposite side and fixed the rod, the reduction was almost complete in our patient. And this was also a high BMI patient with almost 35 BMI. You can see another case with grade 2 listhesis, very nicely done, moderate BMI patient. We have in fact done 5 level adult deformity correction also with this technique, and patient was a very fragile patient, around 40-42 BMI of the patient. Patient was bedridden since 6 months, and next day onwards patient started walking with the walker, and I have now this 7 month follow up of this patient, and patient is walking with the stick. So patient started walking just after 6-7 months of being bedridden. The greatest concern while doing this procedure is whether we will achieve fusion or not. We have started collecting our 9 and 10 months data now, and I'll show you how data is reflecting on our patient. But these are some of the cases where intra-cage fusion we have seen on CT scan on follow-up. Also, the lordosis has very quietly maintained. There is no sinking of cage, and patient also had a beautiful indirect decompression, as you can see in this image. This is the pre-op and this is the post-op. You can see this axial pre-op and axial post-op. Very nice indirect decompression, and you can see the bony bridge inside the cage. Our data so far shows we have inserted around 75 cages in 55 patients. Highest follow-up we have 12 months. 25 patients completed more than 6 month follow-up, one showing signs of delayed fusion. 24 patients shows bridal type 2 fusion, one cage migration grade 1, fused at 7 months without significant clinical consequences. Median ODI at 3 months was 18, and 6 months it was 20, and median pre-op ODI was around 82 for all our patients, and ODI dropped down to 18 at 3 months and at 6 months 20. Excellent outcome in 48 patients, good in 6, and one patient has a fair outcome wherein the delayed fusion is, we are hoping that it will. To summarize, it is a technique that uses principles of indirect decompression, takes up a time-tested corridor for assessing disc. It is similar to ATP in many ways, and we term it as posterior to psoas approach. It can be performed under local anesthesia, but I always performed under general anesthesia. Intraoperative neuromonitoring is must. Thank you so much. I hope this video is instrumental to you in your journey with KLIF. Thank you so much.